Well, great. Okay, well, we got the introductions covered. So I just wanted to go over the agenda, the purpose of the call. Then we'll ask you to describe a little bit about your health center and why you decided to apply for the project and what you hope to get out of it. We are going to skip the clinical training needs assessment today and go right on to the performance improvement assessment review. And one of the last things we're going to do is just talk about next steps.
Okay.
Okay.
So the purpose of the call is really to allow us to learn more about your health center. We know a lot about it through the application, and we intend to get even more information from the assessment, but nothing beats talking to people and hearing it from you guys. Ideally, we would have liked to have done a site visit, so we would have met face-to-face and seen your clinic and seen the services you provide, and we would have done the assessment that way, but this webinar teleconference is sort of the next best thing.
Okay.
And of course, we are excited to meet you all, in about a week or so at the community meeting, so that'll be a chance for us to further get to know one another.
Okay.
So could you just start off by letting us know a little bit about your health center, why you applied to the project, and what it is you're hoping to achieve from the project?
Okay, we are a federally qualified health center. We have been in existence since 1979. We have 3 fixed sites. We got 2 school-based clinics, and we also have a mobile medical unit. In our service area, we serve a 5-county area. We have about, right now we have on staff about 13 providers, with 6 of them being doctors and about 7 nurse practitioners. We see in the neighborhood of around 12,000 patients a year with about 45,000 encounters. We have participated in other HIV programs before, and we thought that since HIV is becoming prevalent within our service area, it was something that we wanted to get more involved in. Right now, we do have 1 nurse practitioner who went through some HIV training, as well as I think we have 1 nurse that's been through some training, and we also got a nutritionist on staff.
Great. Great. And just briefly, what kind of where do you hope to go as a result of the project?
Well, we're looking at a better way of serving our community, because HIV is going to become one of the things that HRSA is going to be looking at in the future. So we wanted to make sure that we be able to service all patients within our service area, being able to give them the appropriate care that each disease might need.
Great. That's great to hear.
HIV is kind of prevalent within our service area, so we want to be able to make sure that there's no one really in our service area right now really work with the HIV population.
Great. Well, that's really good to hear that you're taking on that challenge, and we're definitely here to help you. So we do at some point want to have some more discussions about the clinical aspects of your services. That will be done at a later time, and today we're going to focus the 1 hour on the performance improvement aspects. And I'm going to let Mazdak lead us through that, and I'm actually going to step off the call and leave you in his capable hands.
Okay.
Thank you, Jarrett.
All right. All right. Good to meet you. Thank you very much.
Great. So thank you for that background. I think it sounds like you all are exactly the type of health center that we were looking for this project. So I'm excited that you all will be joining us. What we're going to be doing now, and I'm wondering, since we got started a little bit later, do you all have time to meet for a little bit later as well today?
Yeah, we should.
Okay. So we'll try to get through as much of this as we can. As Jarrett mentioned, you're going to have another call with the clinical team to try to assess what some of your clinical goals are for this project. But as AETC realized when they're putting this project together, and as I'm sure you've all realized from all the other projects that were similar to this that you've all taken on, that clinical improvements can't happen in a vacuum, and that a lot of times that there's these performance improvement work that needs to happen simultaneously so that the changes will stick. And so what we're going to do in this section, and I know that you guys are working on filling this out, so you're going to have to fill me in on some of these answers while I go through this blank form. But we're hoping to identify some areas from now through the end of December, when we'll be working with you on this part of the project, that you all will prioritize and really want to spend some time concentrating on to help you all better serve populations living with HIV and who are at risk for HIV. So we've broken it down into 4 different sections: revenue maximization, quality improvement, access, including both cultural competency and appointment access, and also some reporting population management work. So do you have any questions before we get started?
No, not right now.
Okay. So first, in the revenue maximization section, I know we asked in your application what your breakdown was of how you get reimbursed for services, and at that point you had put down that you all, about a third of your client base is uninsured, about a third gets Medicaid, and then the rest, 15% gets private insurance, and the rest is Medicare and CHIP. Is that still accurate?
It's pretty much close to it, yes.
Okay. And you also mentioned that you all receive, you collect information on the percent of rejected healthcare claims that you get back, and that was at around, I believe, or do you know what the most current numbers is?
I haven't had a chance to look at it. I ran it last night, but I hadn't had a chance to really look at the number yet.
Okay.
It's somewhere, probably, our rejected claim is probably somewhere around the neighborhood of 12 to 13%.
Okay. I think we, on the application, you put 15%, so it sounds like right around that ballpark.
Right.
Okay. And can you tell me right now, like, what's the process when you get those rejected claims at 15%, what you all do with those?
Well, we got some back office billing people. They look in to try to find out what reason they rejected for. And then once they find out the reason they rejected for, they go in and put in the correct information, and then they resubmit the claims back out. A lot of times it might be a diagnosis problem. Sometimes it just may be something that wasn't clicked inside the system. And then a lot of problem we're having right now is with the 5010, making sure all the information in the system is correctly when the information is going out.
Gotcha. Okay, and how is that process working? When you then resubmit, are most of those claims then settled, or do you still have a... Say that again?
For the most part, most of them are settled. The only one that we probably be having a problem with are some of the things that we got to do system changes on, like for 5010. And those we have to usually go back to the vendor to try to find out why they are really defaulting. And we have a little problem with Medicare sometimes, making sure our numbers and everything are correct in our address, because they just brought me a few things this morning we're working on with the vendor to make sure it's in the system correctly.
Okay.
But that's what most of our problem is around now, though, with 5010 and making sure the information in the system is correctly going out the way the vendor wanted it to be.
Great. And that your vendor is Allscripts?
Allscripts,
Okay, great. So it sounds like you all have a pretty good handle on that right now. Is that an area that you think you would want support on from us about handling that process with the rejected claims? Or does it feel like you have that pretty much under control?
I think right now I feel like we got it pretty much under control, especially, but it will be something we're going to be looking at in the future because that has been assigned to my group to look at. We kind of like in our PI committee, we were broken down into different groups, and one of the things with me being the chair of the finance, that's one of the things they have given me for performance improvement measure to look at ways we can. So we got a goal of wanting to try to get our denial rate down to below 5%. So that's one of the performance my committee has been given.
Okay.
So it could be once we look at all our problems, we might need technical assistance once we look at it and kind of get a handle on what is causing all our problems.
Mm-hmm. So great. So I will mark that down, and as we go through more of these sections, we'll figure out if that's the priority, the main thing that you want us to work with you on, or if there's something else. But I think that's great that you've already identified a goal, and definitely that's something potentially that we can help you out with once you dig deeper into the issues.
Okay.
Okay. Can you tell me a little bit more about how you get compensated for the uninsured, the third that's uninsured?
Okay. Mostly they're set on, because we are a federal qualified center, they get set on a sliding fee schedule according to their income.
Okay.
So a lot of it is with the 330 grant that we get to help subsidize their costs. And then we got a minimum amount of $25 that a patient has to pay. So
okay.
We do bill the patient for theirs, but we also, that's mainly the 330 grant is off to help cover the uninsured.
Gotcha. And then how good are you all about collecting that $25 from the patients?
Right now, it's a process that we're working on also. Some patients pay real good, but we probably, at the end of the year, still writing off about $300,000 to $500,000.
Okay. So that is actually something that a lot of our health centers are struggling with. So one of the things that we're working on with some of them is figuring out best practices for how to get more reimbursement from the self-pay folks, the sliding scale folks, and not as a way to create a barrier for them to come, but to just get their fair share from folks that can afford it maybe, but know that they can get away with not paying, so then they don't. Is that something that, but I have to say that actually that rate that you said is better than a lot of the folks that I've been talking to have been getting back from their patients. So is that an area that potentially you think you'd want some support around, or again, do you feel like you've got that pretty much under control?
It could be once we really sit down and look at it, but like I said, we probably, for our uninsured, we're probably around the neighborhood of maybe 20–25% collection on them. So it could be something that we're going to look at into our PI committee for seeing how we can raise that up some.
Okay.
Without being a barrier to access.
Yeah. Great. So we'll put that down.
Also, just want to let you know, our CEO has joined us now also.
Yes, Aurelia Jones-Taylor. I just joined the call. Sorry I had to be late, but we had two things going at the same time.
No, I understand. Thank you for joining the call. My name is Mazdak Mazari, and I am one of the performance improvement coaches on this project. And so what we're doing right now is just going through an assessment to figure out what your health center's main performance improvement needs related to better serving populations around HIV are, so we can develop a project plan for what we're going to work on together from now through December.
Okay, very good.
Great. So I'm just going to keep going on. So can you tell me, for your state, I know it's reimbursement for services is different in different states in terms of if it's a per patient per month, or if you all are reimbursed at higher rates based on the acuity of the patients that you see. How does reimbursement work for you all?
Well, as far as Medicare and Medicaid, we on the PPS rate. We get a rate no matter what we do when we see the patient. That's what Medicaid and Medicare. And then with the third party, It's just like any other person who bill. We get based on according to what we bill out. So the doctor can bill high, they spend more time with the patient and all the service they provided. So we get reimbursed whatever the fee for service is for a third party.
Okay, so if you did code for more acute patients for the Medicare and Medicaid in your state, you would be reimbursed more, you're saying?
We get reimbursed the same.
The same, okay. The reason I asked that question is because for some folks then, the coding becomes really important for knowing how to code correctly for the services that you are providing for HIV positive and for HIV testing. But it sounds like that might not be as high a priority for you all since you're getting paid the same anyways. Is that accurate?
Yeah, for Medicaid and Medicare,
yeah.
For other third parties, it would be a problem. You know, we do need to be sure we're coding correctly. But even though we're the same pay for service, we still have to code properly, though.
Yeah. No, I know. Some people just make it more of a priority or less of a priority based on that. So how comfortable, I know you mentioned that you already have some providers that are comfortable seeing HIV-positive patients, and that it looks like based on your application, you all do provide universal HIV testing. I'm wondering how comfortable are your providers as a whole in doing HIV-related coding?
Well, they do it, you know, because we have patients that
I think we're better at some sites than others, because we do have some newer physicians who may not have the experience as others that have been with us quite a few years. So I think there might be some opportunity there to kind of do a refresher.
Okay. And how do you all provide training for providers around coding now, currently?
Well, we had a consultant that came in and did a building and coding workshop at one of our annual meetings.
Okay.
And we just focused on the providers. Mm-hmm. And she went through a whole, maybe how many hours was it? A 4-hour session on billing and coding with the providers. Great.
So one of the things we could potentially do is just do that specifically around HIV for folks that might not be as comfortable.
Mm-hmm.
Okay. Great. So we answered some of these questions already. I'm trying to see if we missed anything. Just in general, I guess, so we went over 3 different areas right now, collecting more compensation from uninsured clients, making sure we get the proper billing, coding for HIV-related services, and then making sure like that process is airtight around reducing the amount of rejected claims. Is there, out of those, or is there anything else that you all think you want the most support around in terms of anything revenue related to make sure that you're better able to serve this patient population? Is there, out of those 3 or anything else, is there anything that you all feel like you would most want to focus on?
Not right now. We don't see.
Okay. So we can come back to that, but so it sounds like you guys have got a pretty good process going there right now. So maybe one of the other areas will be somewhere where you will all want more support. Anything else that you want to share with me around revenue maximization or questions that you have for me?
Not right at this moment. As we get further into this collaborative, we might have some different challenges and stuff that we might need to address.
Sure, that's fine. And yeah, this plan that we develop is definitely not going to be set in stone. And as as you said, if you learn more things through the collaborative, or if different things come up, you can definitely feel free to keep in communication with us, and we'll shift accordingly. So the next is the quality improvement section. You mentioned that you do some quality improvement around revenue. Can you talk to me a little bit more about the quality improvement process at your health center, who's involved, and what that looks like?
Okay, well,
Why are you guys laughing?
Because we asked the QA nurse and she said, no, she didn't want to talk about it.
No one wants to touch that ball?
Our quality improvement team, it consists of all facets of the health center. We got providers who's involved in it, nurses, front desk people, janitors, people in transportation, front desk people. So we got somebody really out of every department who takes a part in the PI process. And in there, we kind of divided up in between 4 different committees. We got a quality and service, access to care, financial, and utilization. And in each of these committee chairs is kind of headed by a provider, and then we have other people in the committee serving on it. So we also got a risk and corporate compliance committee, which actually looks at things around the health center that probably need to have some improvement done, or things that we might feel like we don't know how we're really doing on them. So then that team then sort of like go back and do the audits on those different functions. And when we do the audit, if something is below a goal that we think that we should be at, then that is then sent to a committee in order to do quality and performance improvement on.
Okay. And do you all use like a PDSA method to get at meeting goal, or do you have a different kind of quality improvement strategy?
No, we
use PDSA, the chronic care model.
Okay. And how comfortable is your staff with using that model?
We've been doing it for about 100 years now.
Yeah. Great.
But then we have to continuously train on it because staff changes.
Yeah.
We have people who come. It's a continuous process.
One of the things we're working on with other health centers is, because a lot of people are very comfortable and familiar with PDSAs, but sometimes that's just within the QI committees, and so we're working on this idea of creating a culture of innovation so that everybody in the health center understands what a PDSA is and what their role is in that PDSA, and as you were saying also that whenever there's staff turnover to continue that, so that's a part of how the health center operates. Is that something that you all feel like you could use some support around, or is that something that you pretty much do on your own well?
Sure, we will take that support.
Okay. Great. And do you have any specific measures right now around HIV that you all are trying to meet or are tracking?
The only one that we really track is how many tests we do for patients 13 to 64. That's the one that we report on. How many tests, how many are refused, and positives and the negatives and so forth.
Okay. And from my understanding, everybody that comes through the door is offered an HIV test, correct? And they can opt out. Is that how it works?
Correct.
Okay.
That's correct. Between that age group.
And what do you all happen to know what the refusal rate is currently? Okay. We can ask you that. And the reason I ask that is because some health centers that we work with, one of the goals they're working on with us is to reduce that refusal rate. They have a really high refusal rate, so they want to reduce it.
Well, we screened about 400, and out of that 400, we had like 50. Most time, they come and ask for it, so we really don't have a problem. So I'm looking at like we was like a 87 or 86%. Which was left about like 18 to 20% refusal.
Okay, that's not bad. And what is your? Sorry, go ahead.
Most during our care stage, most of our family planning and it's just incorporated in our evidence-based practice. It's just part of a practice that be done clinically. So we don't have a lot of rejection.
Yeah, that's great. And actually, if I think a lot of other health centers can learn probably from how you've incorporated that into the way you do business during the family planning. So I would love if you all during the community meeting or maybe some future session could share how you all were able to manage that, because not everybody is there. So how do you have any or the seropositivity rate, do you know what that is? How many people? I know that you said for your last reports that you all were providing services for 10 HIV positive people. Is that the number that you are currently on your rolls, or the number that find out that they're positive through your testing, or both?
We currently have, with the 3 sites, 13 that we are treating, and then regular that we follow.
The question is, did we find those through the testing process, or just we selected them?
They 5 of them was found through the selection process, and the other 2 was already diagnosed and just became, part of our health center family.
Okay. And I saw that you all do have varying relationships with like the nearest Ryan White funded center, and then there was another organization that I think you had a referral relationship with, but that wasn't working out so well. I'm wondering, so if somebody gets tested at your health center and they find out that they're HIV positive, what are the next steps from your perspective?
Well, our next step, we usually do some education, try to assist them if they do not have any finance. First we got to get them over this shock. And so, our goal is to educate them or try to get them the best resources that's available for them. So we
just enroll them in care. Do we enroll them in care at the health provider?
And most of them normally most of them, once we identify them, we enroll them in care there, because that the provider is usually the one that they want to see, and it's their provider. So if we find something, they find something that's just really, really, emergency factor, they do have a collaboration with the infectious medicine doctor, Dr. Griffin over here. We consult with him, about the care. But most of the time, we go ahead and do their labs and, get them to identify, at what point they are in their disease process. So we keep them.
Okay. Great. And so now that you do have the one quality measure around HIV testing, are there any quality measures that you can think of that you'd want to include in terms of HIV care or linkages to care?
Well, we always could have other resources to link them to, if they get out of our scope of practice. So, we got DePores that basically is mainly a HIV clinic, but it's located in Quitman County. But we have an infectious medicine doctor, Dr. Griffin, that's really good, and that would collaborate with our nurse practitioner and doctors for referral and counseling for a patient.
Great, so that you're able to keep most folks inside.
Yeah.
Okay.
We, and have somebody take over their care if they have to be, admitted into the hospital for other processes that's going on with HIV. In the past, we was collaborating with, I think, Monica, what her name? Cheryl Monica. You might have heard of her. Cheryl. Yeah. That and was dealing with HIV patient, and they was out of the clinic in Jackson, from the Jackson area, and where we would put our patients into a system called CareWare. Have you heard of it?
Yeah.
And then we collaborated with the HIV specialists, the doctors up there, And if we was to send data in, they would come back and teleconference with the provider in-house.
Okay.
That's something good if we could have, some connection or teleconference with HIV provider, doctors that specialize in that disease to assist our providers if they, just have some questions or find some new areas that they just don't understand.
Okay. So that's in addition to Dr. Griffin to get more of those connections.
Yes.
Okay, and that's definitely when you guys have the call around the clinical measures, that's something that they can work with you on. But I will note it here, so we'll know to follow up with you on it. Okay, is there anything besides that culture of innovation stuff that I was talking to you about that you all would want support around your quality improvement process or your ability to do PDSAs?
No.
Okay.
Nothing we can think of right now.
Okay. Well,
We
yeah,
did-
feel.
After this, we might find out a lot more than we had me to realize.
Yeah, I know. I mean, we definitely will. We'll keep having conversations, and if stuff comes up, let us know. But it does sound like you all are pretty solid. So the next section is really around cultural competency. And so I do recognize that you all serve a very diverse population, mostly African American. I'm wondering what your health center's approaches are to address issues of cultural difference between staff and the populations most impacted by HIV and AIDS in your community. So is there any sort of training that you all do around cultural competency, or how do you all tackle that at your health center?
We've had cultural competency training
Uh-huh.
on several occasions, and each of the staff providers did something with NCQA on cultural competency. It was kind of a I can't remember what it was right now, but it was a training that they went online and did and took a test thereafter. But pretty much we have language interpretation type services in the site for those Hispanic patients that we have. But around HIV, we have an AHEC program that also provides some training around HIV cultural competency. But other than that, we don't have anything ongoing.
Okay. And who are, it's different state by state, who do you all see as the communities that are at highest risk for HIV in your area?
Students in high school. High school students, and who else? They're mostly heterosexuals, I guess.
Okay. And are your...
She said middle age. She said she sees
middle age. Okay.
Yeah.
And do you all have any sorts of, I know some places, some providers aren't comfortable asking sexual risk questions to everyone or behavioral risk questions that can lead to HIV infection. Do you all have any sort of support for staff around doing that as a routine part of care, or is that even something that your staff struggles with?
No, those questions are asked, about your sex partners and when, how many you have. I haven't identified any problems that the staff have asking those questions because, it's so prevalent, now that it's something we just have to ask.
Gotcha.
Now, I don't think we have any problems with the questions around sexual activity. We may have a provider who is not comfortable with treatment, and we have to acknowledge that, and that's something that he thinks he's a minister. So I think that's his whole issue. But by far and wide, for the most of the staff, we don't have that problem.
Okay, and for that one provider who's not comfortable with treatment, do you all just give those patients to somebody else, or how do you address that?
Give them to somebody else within the center. We have a provider in every center who will treat.
Okay, great. Would you all be interested in more support around cultural competency trainings, particularly for populations that might be at higher risk, like potentially gay male populations or intravenous drug-using populations, also high-risk heterosexuals? Could you all use more support around that sort of training?
Any kind of training is
Yeah,
welcome.
yeah.
You know, because it's really, this day and time, it's just hard to identify who is who.
Right.
So,
Yeah.
that if anything can add to us, you know.
All training is welcome.
Okay, great. The next area, and any other area in terms of cultural competency that you all feel like you'd want more support around? Is that a no?
No.
Okay. So the next area is around access around recruitment and retention. So I know you all said that folks actually come to your clinic, the health centers, and ask for HIV tests. We're wondering if you have any barriers to recruiting people living with HIV and AIDS into your health center.
Yeah. But we don't know what the barrier is.
Don't know what they are.
We have a clinic in Tunica, Mississippi, which is near Memphis metropolitan area. We had a grant for early intervention, I think, a grant around HIV. And for that whole year, we did not get one patient referred into our health center. So I don't know if it was the staff that we had that was not doing appropriate outreach or what, but we just, you know, in most small communities, it seems that patients who are HIV positive tend to want to go outside of their community to receive care.
Yeah.
So we haven't figured out how we can really attract more patients. Now, we haven't tried to go out there and attract them a lot because DePorres is 20 miles from us and they have the grant. So
I see.
Well, that's our issue, though. But if people want to be seen by our providers, we accept and provide that care.
Well, that is definitely something that we can work with you on, is to maybe identify what some of those barriers are and try to work on recruiting more folks into your system. Is there anything else in terms of past efforts to recruit people living with HIV in your health center that you'd want to talk about, or is it pretty much that one program in the small community?
Yeah, we did a big outreach. What was that event?
It was downtown. We partnered with, forgive me, the name slips my memory, but it was a man that had come into the area that was doing a lot of recruitment around HIV and AIDS, and we did a large outreach event where we did the testing and the health fair type setting focused on HIV. What was it?
Party with a Purpose.
Party with a Purpose. And that was a success. Yeah. Well, you saw several individuals come through, you know, I mean, as far as just that came to get information, if nothing else. They may not have gotten tested, but we had several that did come and get some literature education.
There's still a stigma. There's still a stigma here.
Yeah.
So we're in the Bible Belt, and we may have to overcome some of that.
Yeah, and is it stigma both around HIV and the behaviors that?
Yeah.
Okay, so both. Okay, and the last question in this section is around retention, actually. So can you all talk a little bit more about how well you all are able to retain HIV-positive clients within your system, and any efforts that you particularly make to make sure that they keep coming to their appointments and stay within your health center system?
Well, I really haven't identified any problems with retaining them because we retain them, and what we usually do is we track them. We keep a log of them, and they receive a phone call if they miss their appointment. And usually the ones that are incorporated into our services, they are pretty well, connected with us. So we don't have no problems with them coming. They might miss the appointment now, but once I call them, they'll come. And
Okay.
we usually let them do a self-management goal sheet. You got to keep your promise. This is what you promised you'll do. We identify when you're going to get your lab. So, the majority of them, we don't have any problem with them. They'll come in.
Great. And do you all track to see if they're coming in for at least 2 visits per year, in addition to seeing if they miss appointments or don't miss appointments?
Yes.
Okay.
We
You do track.
a log of them, and that's how I identified, who have missed, what you need. Is it your 3-month lab is due, or is it time for a flu shot this year? You didn't get your pneumonia shot, or is it time for your hepatitis A? Did you ever receive your series? So we track them, and
Okay.
they.
Great. So it's about 1 o'clock right now. I'm wondering if I can have you all since we got started a little late, have you all for another 10 minutes or so.
Sure.
Great. Did someone have something to add? I heard an O.
No, that was Richard talking out of the door.
Oh, okay. So next, I know that you all in your application said that you were going through the NCQA PCMH recognition process, and I know a big part of that is appointment access. So wanted to know if you all could please walk me through a little bit about what work you've already done around appointment access, if any, what your goals are, how that's going, how we can help support you.
Well, I think our goal as far as our appointment access is to become an open access clinic, whereas we can do same-day appointments for our patients.
Okay.
We're also looking at with trying to be meaningful use, and with the patients in the medical home, looking at the patient to be able to go online to set up their appointment and stuff. Mm-hmm. Those are some of the goals and stuff that we got around within this next coming year to try to have the patient available for the patient, and also to set up a patient portal for them also.
Great. And so how far have you gotten so far in all that work?
A lot of it we just beginning, because a lot of it's depending on our EMR vendor and different stuff for like the patient portal and for the online access. Right now we are working with the staff on training them on open access on how to set that up.
Okay. Is that an area that you might want some support around, or how are you getting the support around that now?
We mostly doing in-house and looking online through some of the other collaboratives we've been in, but yeah, that's something we could use some TA on.
Great, and there's definitely a lot of materials that are on the virtual learning lab, which you all are going to have access to around access that hopefully will be helpful. Specifically for HIV patients, if someone wants to get an HIV test, or there's a new patient that has been identified as HIV positive and wants to see a practitioner, how long would they have to wait to get an appointment generally?
Well, probably next day. If they already a new patient, well, if they're already an established patient, they can just walk in and get seen same day. But if they're a new patient, next day appointment.
That's great. Okay. Cool. So so it sounds like you all are already working on that and just need maybe whatever support we have in terms of your in-house work that you're already doing.
Yeah.
Yes.
Okay, and finally, the last section is on reporting and population management, and I know that you all are probably doing a good amount of this work too in terms of the PCMH recognition process. do you currently have at least 2 staff members that are trained on how to navigate the analytic tool within Allscripts?
No,
Or
not right now.
No, okay.
Well, we have one staff member who's kind of worked with it, but we also work with Delta Help Alliance as far as a lot of our analytical reports that we get.
Okay.
They have a whole company for that.
Great. And do they help you collect reports on the HIV positive population?
They will.
Not specifically, but they will.
They will, okay. And do you all have the ability right now to do cohort reporting or panel reporting where you can follow a group of patients that you, like HIV positive patients that you may have tried one intervention with over the time and separate those from maybe folks that haven't gotten that intervention so that you can see the impacts of what you do with them on their health outcomes? Is that something that you do currently with other health issues besides HIV?
Well, right now, through our EMR, we don't. That's something we're working with Delta Help Alliance to get set up. But we do have another software that we use to track different patient population. Do this on the patient population?
Well, we do. Yeah. Mm-hmm.
Okay.
Diabetes, hypertension are our 2 major focuses with that, but we have other populations in there as well. It does track it by population.
Okay.
And what's that other program called?
Altruistic Health is the company, and it's called Guiding Care.
Guiding
It's
Care.
a care program.
Okay. In terms of reporting and creating patient registries, that sort of thing, what sort of support, if any, do you think would be helpful from us?
Well, we probably wouldn't need it because, like I said, we're in the process now of trying to get it set up through our EMR on tracking. They do have a disease management, but I don't think it has been set up yet. So any support that we can get in order to getting all that set up and reporting correctly, we would welcome.
Great. Okay, I'm not going to go through the rest of these questions because I think that pretty much covers it for that section. But to recap, some of the things that I've heard around revenue max, you all talked about potentially wanting trainings for coding around working with HIV positive patients, and then also potentially getting more revenue out of your non-insured populations without creating barriers to care. And finally, around just nailing down that process around making sure that you have a minimal amount of rejected claims. In terms of quality improvement, it sounds like you all are on it. The areas that you might want support around are around that creating the culture of innovation so that everybody across the health center, not just those folks that are involved in the QI process specifically, know their role and know the purpose of PDSAs in the QI process, as well as really integrating the new HIV clinical measures that you all will be developing through this process into your existing QI structure. In terms of cultural competency and those access pieces, we talked about potentially working on some of that stigma around HIV and the populations that are most impacted by HIV in your community through trainings or anything else that we come up with. In terms of appointment access, just giving you accesses to any of the resources that we may have that can help you in your process right now. Recruitment and retention, we talked about recruitment, helping potentially you recruit more folks that are at high risk for HIV/AIDS or HIV positive into care in your health centers. And then finally, reporting and population management, as you all are working to set up the population management for HIV to help you out with that process. I know that was a lot of words I just said. Did saying that make you all think of anything else, or did I miss anything?
I think for right now you covered most everything.
Okay. Out of all of those things that I said, are there 2 or 3 that you know that if these are the only things that we did, this is what we'd want to focus on or focus on first?
Probably revenue maximization.
Okay.
Let's see. This with the recruiting the population,
Okay.
and then the population management.
I like that.
Great. So what I'm going to do in terms of next steps for this is turn this conversation into a proposed project plan. And it'll have in each of these areas the areas that we're highlighting to work on, but really focus on these 3 areas that you just talked about: revenue maximization, recruiting, and population management. And then you'll have a chance to look at that before we all meet together in DC. And then when we're in together in DC, we're going to turn that into a 6-week implementation plan. So talk about, for the next 6 weeks, how are we going to get this project started? And then we'll go from there. And on the clinical side, what they're going to do is do kind of a similar process with you to help determine what your clinical goals are, and then we're going to combine those plans so we'll know what we're going to work on for the rest of our time together. How does that sound?
Sounds good.
Okay, and then in terms of next steps, what we're going to do between now and the time that you leave our community meeting, April 19th and 20th, you'll be assigned a performance improvement coach, or we'll do our best to assign you who's going to be working with you, as well as a clinical coach, and you'll be introduced to the coordinator who's going to be coordinating this entire project and will be your main contact. On the clinical side, they're going to be sending you some self-assessments for your providers that are going to be wanting to ramp up in their ability to serve HIV patients. And then you're going to begin that assessment-based training plan. And then on our side, we just talked about what we're going to do. And the best practices that we found is to slot out a time for 2 hours a week, and we don't think that everybody on your team needs to be there for the full 2 hours, but that we would meet with each of your teams, whoever's working on revenue maximization, whoever's working on recruiting, whoever's working on population management during that time. And as we move forward, if we see that less time is needed to get the work done, we could move to that, or more time is needed, we can work to that depending on your schedule and your other priorities. But I'm wondering, do you have a time right now that you think would work the best for meeting with your staff, or do you need to go back to your to folks and Okay, so if between now and our meeting in DC, if you all can think about what a nice 2-hour slot would be within the week for folks to meet around this. And then other than that, we'll see you next week. Any questions or comments?
Nope, I don't think so.
Okay, then very quickly, I just kind of want to assess with you all how this process was for you guys, what worked well about it, and anything that didn't work well about it or that you'd want to change as we continue to work with each other in the future.
Everything was just perfect today. First time, we just a little slow getting on the call and everything, but
well, now that'll get easier, I think. Yeah. Okay. Well, I don't want to put you all on the spot, but if you, I hope that we can create this open communication, and if there's something that's not working for you all, that you'll let us know, and the same for our side, and we'll try our best to just make sure that this is a good working relationship for the whole time that we're working together. And it was a pleasure speaking with you all, and I'm really very impressed with all the work that you are already doing, and look forward to working together to make it even better. And please look out for an email with a project plan. If we can't set up a time, actually, do you all have a time early next week before you leave for DC for maybe half an hour that we can go over the project plan that I'm going to turn this assessment into, for you all to talk about whether it makes sense to you or not?
Tuesday afternoons are the times that we have set aside for meetings. So
great. Okay, I'll send out something then for you tomorrow, and then we'll decide, and we'll try to do it sometime Tuesday afternoon.
Okay.
Okay? Thank you all so much. Thanks for your time today, and we'll see you next week.
All right.
Okay.
Bye-bye.
Bye.